Appreciate you all for being here today. I will be discussing a case I had the opportunity to see in the retina clinic about a week ago. It was presented from the emergency room for urgent retinal surgery. Thanks to Dr. Ahmed al-Shirbini. He's the surgeon of the case himself, and he's the one who suggested me the case to present in this grand round. So the story is about a 34-year-old male patient came with a present history of sudden drop of vision in the right eye and pain post-trauma just the day before. He said he was hammering when he felt something stroke his right eye, and just right after he felt the pain and drop of vision. Having a look about his past history, he denied any previous ocular surgeries or any previous eye traumas. He was not on any current medications. The medical and surgical history revealed nothing as well, and he was in a fair general condition. His baseline eye examination showed the following. The best corrected vision in the right eye, the affected eye, was hand motion, and the other eye was 6/6. The anterior segment examination showed a temporal sealed corneal wound. The AC was formed, and the iris showed a temporal, regular, and rounded defect, like a hole, and he had a traumatic cataract as well. This is an image of the iris defect. It was taken intraoperatively. Unfortunately, I don't have a preoperative image, but I just wanted to share the iris defect. And the anterior segment examination was strongly suggestive that something had penetrated the eye in this manner, just like this image. The fundus examination was hazy. So what's next? We have an eye trauma, which is by definition a head trauma. So CT scan of the brain and orbit by default. The history and clinical examination is strongly suggestive of an intraocular foreign body. So this is another indication for CT. We have a traumatic cataract and a vitreous hemorrhage and a hazy fundus view. So B scan was ordered as well. The B scan and the intraocular foreign body, it can detect, but it's highly user dependent. So unlike the CT brain, which is almost 100% sensitive. This is the B scan, where you can observe the vitreous hemorrhage and a hyperechoic area. Something is hanging in there. These are the CT sections of the patient. This is the corona section, and this is the sagittal section, and this is the axial section. Metallic intraocular foreign body is clearly visible, and if you have a look over here, the axial section, you can tell how critically situated it is, just temporal to the optic disc, embedded in the macular area. Okay, before discussing what was done with our patient, all patients with intraocular foreign body are by definition penetrating open globe injuries. And our major goal usually is to repair and to reconstruct that globe and to remove that piece of foreign body outside of the eye, since it has a large potential for complications like infections and toxicities that might not only lead to vision loss but also loss of the eye completely. However, our all intraocular foreign bodies must not be left in the eye. To answer this question, foreign bodies can be classified into many classifications, such as per the material into metallic and non-metallic. The metallic make up the vast majority of the foreign bodies, by the way. But the classification that matters the most to me is whether this foreign body is toxic, inert, or infectious. And what we mean by inert is that it does not induce tissue inflammation. It does not induce reaction. It's safe for the body. Just like the glass, the plastic, ceramic, gold, and silver, you can leave them unless they are posing a mechanical injury. For example, if you have a glass with sharp or spiky edges, of course you will not leave it and you have to take it out. The infectious foreign bodies, like wood, they are mostly contaminated, and they have a large potential for endophthalmitis. Unlike the metallic intraocular foreign bodies like iron and copper, they are mostly heated and sterile. However, they are toxic because they induce a chemical injury. The most common two toxicities is siderosis caused by ferrous and chalcosis by copper. Siderosis is the consequences of interaction between iron ions and ocular epithelial cells. It can affect the cornea, the trabecular meshwork, inducing glaucoma, the anterior capsule, the retinal pigmented epithelium, and it's toxic to the photoreceptor. If you have a chronically presented patient with iron foreign body, encapsulated, the eye is stable, no vision threatening. You can follow up this patient with ERG. Siderosis affect the B wave even earlier than the clinical manifestation. And if it's affected, you have to go and take this foreign body out. About chill causes, it's a reaction to a copper-containing intraocular foreign body. The course is actually variable depending on the copper content in this foreign body. It might be acute endophthalmitis-like picture, which is it's a fulminatic condition and it needs urgent intervention. And it might be chronic, taking weeks to months. It tends to react and deposit in the cornea and different ocular structures, cornea, the lens, retina, specifically the ILM. And you can follow up these patients with ERG as well. The decision to remove the intraocular foreign bodies, the timing, the urgency, it's variable and it depends on many factors like the size, the location, the association and complication, and the impact of this foreign body and the different ocular structures. This table is highly informative in this area, but I'm not going to go deep into it because I don't have enough time. But I just wanted to deliver that the management plan of the intraocular foreign body is literally tailored for every patient and for every single foreign body. How can we get this foreign body out of the eye? We have two exits. Posterior approach through a widened sclerotomy, and you can use this approach in cases of when you're going to preserve the lens, for example, or if you have a small foreign body. The anterior approach through a corneal or limbal incision. Okay, back to our case. We have a young patient, acutely presented, a metallic intraocular foreign body, mostly iron, vision hand motion, traumatic cataract and vitreous hemorrhage. The wound was sealed, the globe was formed, the I0FB was maintained, so the eye status permitted an intervention. If the globe was not formed and the wound was open and the I0FB was not maintained, you should go for primary repair first and then wait for 10 days to 2 weeks and then take that foreign body out. But in our condition, this was not the case. The globe was formed, so the decision was to do lensectomy, first plan of vitrectomy, and intraocular foreign body removal through an anterior approach. This is a recorded video of the operation, lensectomy, for vitrectomy, PVD already done. This is the foreign body. It was partially subretinal between the optic disc and fovea, grabbed using a forceps up to the anterior chamber. Using iris shelf technique, he used the iris as a shelf to help keeping the foreign body in place. And it was delivered through an already done limbal incision after coating the endothelium with viscoelastic. And this is an actual image of the foreign body. This is a colored photo of the fundus 1 week post-operatively, and you can see the track at the site of the foreign body. Okay, for anyone who's wondering, no laser is done in this area. The eye is left on silicon 5000, and the vision is on +4, counting finger 20 or 25 centimeters, which is an awesome outcome, to be honest. So we have come to the end. My take-home message is eye protection, eye protection, eye protection. The most valuable piece of advice you can give to these patients and to these type of workers is to wear goggles and to protect their eyes. Protection is always better than cure. CT brain and orbit is a must in eye trauma cases. MRI is contraindicated when metallic intraocular foreign body is suspected. A good history taking and a meticulous evaluation is an important key to success in intraocular foreign body cases. And thank you. Thank you so much for listening.